esteemed chairpersons for the wonderful session on typhoid vaccine. And a big thank you to our audience and our seniors seated here for a wonderful discussion thereafter. Now moving on to our next session, which is on breaking diagnostic barriers in pediatric infections with next generation sequencing. I would like to call upon our esteemed speaker, Dr. Mahua Das Gupta ma'am, and our chairperson, Dr. Abhay Marathe sir.
A very good afternoon. I feel very honored by my presence in this room. I thank respected chairperson, all my seniors, my friends, juniors, for giving me this opportunity. As I mentioned, I'm the odd one out in the room. I'm a clinical microbiologist trained at PGI Chandigarh. Was very fortunate to see the Apex Institute in Pediatrics during my postgrad years, and then again equally fortunate because I was working very closely with a neonatologist who happened to be my batchmate in PGI. And I have seen and felt the toil, the challenges, and I always regarded the subject as well as the fraternity in pediatrics with high esteem, because I don't think they ever get a very sordid symptoms being mentioned to them or a clinical history which is coming from the patient's mouth. All they know are the wails and the tears and the cries, and they have to interpret. They're left to interpretations. So kudos to all of you. I learned a lot ever since I joined all the sessions since morning. It has been a learning experience. I have been allotted 15 minutes, so I probably will rush through some parts of the presentation. Please feel free to reach out to me if I leave you behind more confused than what we start with. The intent has been to break certain diagnostic barriers. I'll speak and focus more on pediatric infections, though as a microbiologist, I think it is my duty to be a good support to your clinical journey with your patients. So if we are robust, we know it makes decision-making easy for you, tailoring antimicrobials easier for you, combating antibiotic resistance, an achievable dream for you. So pediatric infections are well known. They are a global threat causing a lot of morbidity, mortality. The bigger impact probably is also on the long-term outcomes of pediatric and neonatal infections, which go on to impact, I think that is the biggest way the socioeconomic impact is created. And in the recent guidelines, while adult sepsis still had some directional thoughts, pediatric sepsis as well as neonatal sepsis were something which were all the more confounding. In the latest guideline, what really caught my attention was that in the Phoenix score, they mention a score of 2, which involves any site organ dysfunction in the suspected or confirmed cases of infection. Now, when they say that, it means that a diagnostic robustness is imperative for us to be good at diagnostic sepsis. And since morning, I've been hearing of cases where it looked like to be an infectious cause while it turned out to be a non-infectious cause. So improvement in diagnostics are an unmet need so that we are better at combating sepsis. Current diagnostic modalities are very hypothesis driven. When I say this, what I mean is we try to look for what we have thought or experienced. So that differential is very limited. That is the set that we want to look for. That is what is available in terms of the conventional culture-based or molecular methods which are currently available. So these are very hypothesis driven. Let us prove this with the help of a case. So this patient was from a suburb and a 12-year-old male on 6th of November presenting to the hospital at Mahad with fever, chills, and headache. By the 8th day, the patient condition had deteriorated and was shifted to Mumbai at a tertiary care center. By this time, he had also developed signs of serositis, mild ascites, bilateral pleural effusion, and crepitations. The differential also included at this point aspiration pneumonia. All this while when the child was in Mahad, the cultures were negative. PCR, unfortunately, was not available in that part of the country. By the time he was in Mumbai, they performed the entire fever profile as well as the available molecular tests which could be performed, the panel and primer-based testing methodologies which address a limited set of targets. So all of them turned out to be negative. The CSF picture was suggestive of viral. The patient also had thrombocytopenia, a high ferritin, and a high triglyceride. And we had a lot of discussion around HLH in the morning. And this child was a diagnostic challenge by then. So over this time, it was already day 8. He was into the second week. Now, this is the situation probably all of us face, more so the clinicians than the people at the back end. To change from a diagnostic perspective where we are more empowered, what is the global thought? Global thought has been 10 years back stressing upon sequencing as a modality so that it is hypothesis-free approach. We get to see what is there rather than trying to see what we want to see. So at that point, the American Society of Microbiologists had already mentioned the need of moving from time-consuming, labor-intensive, resource-intensive methodologies to a sequencing-based approach, as also they all mentioned the challenges of democratizing such a thing. Now, when they mentioned the challenges, one very important factor was the turnaround time, the cost, the availability, and the accessibility of such a test for every individual, for every country. Especially, these are very challenging for countries like us, which still form a part of the LMICs. Over these 10 years, globally, people are working. All researchers, scientists, medical professionals, colleges across the globe, they are working towards using sequencing for clinical decision-making. And per se, in the pediatric populations, there have been studies, there have been supportive evidence to show that next generation sequencing proved to be better than traditional methods of microbiological diagnosis in terms of their positive % agreement with the clinical adjudication of the case. It impacted therapy decisions like the need to add an antimicrobial, the need to tailor an antimicrobial, the need to stop therapy. And all of this, the correlation of the organism found with the clinical case where cultures or traditional methods had failed to detect. This they had seen both in immunocompetent as well as immunocompromised population, less than 6 years as well as 6 years to 18 years of age. So this was the consensus for the various studies which were carried out. Now that helped the world to think of moving from fixed targets to a more comprehensive overview of what is causing the infection. With this same thought, we, a group of scientists, medical professionals, bioinformaticians, engineers, tech experts, have joined hands. We are an IIT-based health tech company, and we have tried to bring genomic solutions to every doorstep in the country. We have been supported in our journey with some of the leading names in research from the government agencies as well as from the private and corporate sectors. What could we bring was this test, which is sequencing based. It is called the infection next generation sequencing. It is direct from sample, which makes it sample agnostic. We are not limited by what we can handle on this test platform. It has a low performance time, which means a result can come to you from the sample within 24 hours. It is near to the point of care, which means sample transport is not going to compromise the sample and the results, plus the turnaround time, which is very essential in making clinical decisions. It has to be in a clinically actionable time frame. It has addressed the challenge of identifying pathogens. This test can find out any bacteria, any fungus, respiratory viruses in case of respiratory samples, and now also has the capability to detect the neuropathic virus, herpes simplex. Alongside, of course, the 9 medically important antibiotic-resistant genes, which has now become very important in the decision-making and the choice of antimicrobials, because that's how antibiotics are now being developed. It's not enough to know that it is a carbapenem-resistant strain. It becomes equally important to understand whether this is a carbapenemase-producing one and whether which gene is the carbapenemase producer for us to choose between a Septa-Avi versus a Septa-Avi plus Astronum. And to make things easy, so that it looks like easily palatable clinical report, this decision making, the decision making of converting DNA sequences into the interpretation has been done through automation. It has been validated at various centers and now has been peer reviewed, can deal with any test. We have experienced a lot of samples in the adult population when we decided to foray into the pediatric and the neonatal sector. And for this, we saw that when we can detect any organism, we had the proof of evidence. So then what we did was, and that was both in case of bacteria and fungal infections are really on the rise and are a concern as well. All this within 24 hours. This was going back to the first case, the finding using this test. So when the doctor, having experienced failed conventional methods of testing, sent the sample, it was a CSF sample from this patient. What we saw was it was a scrub encephalitis in this patient. Thankfully, the patient recovered, and tomorrow probably will be discharged from the hospital. It's nearly 3 weeks of his illness. A second case, which was a case of a neonate, had underwent laparotomy for jejunal atresia, was in a very bad state of neonatal sepsis, query respiratory distress syndrome, again very confounding to differentiate. Multiple cultures negative, the conventionals not throwing any light. When the sample was sent for NGS, what was detected was Roseomonas. This is not a common name as far as traditional microbiology is concerned. It's a non-fermenter. It is well evidenced in literature to be a major cause of bacteremia in susceptible population. The child, the neonate, fitted into all the risk factors of such an infection. What was important was the child was on fluoroquinolone, tigecycline, and colistin. Incidentally, this shows a 9% resistance in case of fluoroquinolones. Carbapenems work well, and cephalosporins. So the antibiotic therapy could be changed basis the identification, which is the first stepping stone of choosing the proper antimicrobial. Some other cases, just to show you how it acts for various sample types. There have been cases of Cutibacterium acnes, which is a skin flora, in the CSF of a baby where the gram stain had shown, but they could not grow it because it is an anaerobe. It will not grow routinely in a lab. And the patient was treated, it responded to the therapy. That was most important because otherwise, to know whether it's a commensal versus a pathogen. A pus aspirate, now this was interesting because it was from a baby who has been losing out on diagnosis for the last 3 weeks. And the baby had presented with fever. When they performed radiology, bone and liver abscess were incidental findings. The aspirate was sent, so was the blood. Blood didn't show anything on the NGS, so there was no bacteremia, but the pus showed Burkholderia pseudomeli. And the proper therapy could be initiated while the baby earlier was on carbapenems. It could be tailored, cost could be saved, and he could be put on the proper antibiotic which would work for Burkholderia. Last 2 examples. Pus aspirate from lung showing strep pneumoniae, very difficult to grow and identify in routine microbiology labs, often misdiagnosis, and one Enterococcus faecium in a neonatal blood. What is very interesting is this baby was on ceftazidime avibactam because that has become one of the mainstays. Starting a carbapenem and topping it up with colistin has almost become first-line therapy in our country, depending upon the severity of a case. Not colistin, sir, but if the patient comes in septic shock, I agree, no clinician will take a chance because we need to save the patient. Only with a diagnosis which gives you a clue to stop and alter therapy will be bold enough to stop the Septa-Avi and start a vancomycin. I'm on towards the last few slides. Handled nearly about 61 samples in the pediatric, a very small set, just presenting because it's probably been a few months, 2 or 3 months that we have started and forayed into this. We are taking up a large project, now a multicentric project with Dr. Saurav of PGI Chandigarh. He's a neonatologist. So we are planning a study. It has been approved by ICMR. It's called the snaring study. So we are the technology provider for the same. We believe that the world of microbiology is escape. That is the common propaganda. 98% is what we are missing out. Every name, including one that Dr. Sridhar mentioned in the morning, the probiotic organisms leaking out from the gut into the bloodstream was detected. Now I have a number of cases where there was Saccharomyces cerevisiae, which is a commonly used bug in the probiotic regimens. We have seen a lot of bacillus, again, which are used in the probiotics. We have experienced and seen that. So we cannot afford to miss these organisms. Not only are they present, but they are a lot of anaerobes. 23% of what we find are going to be missed on routine cultures and routine traditional methods. The insights that I have are from the, I think I have 15 seconds remaining, no? Okay, I'll spill over by a minute maybe. All the insights that I bring are basis the clinical discussions I had with the physicians, basis the clinical information we have on the sample accompanying TRFs that we get, which is a limited set. Just a second. It's not moving. I need 30 seconds more. Yeah. And whole genome sequencing to corroborate the results. The inference is this has to be a go-to test. This has to be on the right sample. Site-specific samples are wonderful. Blood is not a surrogate for site-specific infections. Of course, we screen blood for seeing whether there is an accompanying bacteremia or fungemia, but that alone will not suffice. The volume of samples are important, the way it is handled, and with that assurance, we can be very rest assured with the high negative predictive value of the test as well. So if this test is not detecting, it is highly unlikely that your patient has a bug. The key takeaways being, let the diagnosis be clinched every time, irrespective of the clinical suspicion of which organism. Conventional testing delays diagnosis. We need to make sequencing a go-to test, and so that the right management is initiated. Regards from my team. This is a very small subset. They're all the scientists of this country. This is purely Make in India, and we want to take this now globally. We are already at the Gulf. So I think with your support, we will make forays into the neonatal and pediatric sector as well. Thank you so much. Open to questions.
Any questions from the audience? A fantastic talk.
I have one comment.
Yes, sir.
So I think it was extremely good data, and this test is going to come. And we have used one of our patients, I think from Jupiter, where this child was having a febrile encephalopathy, encephalitis actually, autoimmune encephalitis, was on multiple suppressive drugs. And after 25 days of ventilatory support, the child started having fever. And we weren't aware whether it was a septicemic fever, bacteremic fever, or non-bacteremic fever. And we sent this NGS, and it came negative for bacteria and fungus. So negative for bacteria and fungus could help us to rule out actually bacteremia in this patient. And we held on, and this patient's fever subsided with anti-inflammatory therapy. So as you were saying that 61 out of 120 became positive, I think it has a great negative prediction value also, and that should be highlighted. Thank you.
Don't fit into the picture.
How does the microbiologist actually help us to figure out which one is the, because
Okay.
you're picking up every small bit of that, whatever is available, right? So you can have a report which has 3 or 4 things picked up.
Absolutely. If I'm allowed, I'll take some few clinical real examples, ma'am, to sort this. So overall, yeah, if the organizers permit. Okay. Okay, to start with, ma'am, the predominant sample types where we usually see polymicrobial are microbiome-rich samples, which are the respiratory samples, the pus samples, the deep-seated tissue samples, where we do expect a polymicrobial. Sometimes we have seen them in the traditionally thought monomicrobial infections, like bloodstream infections. We have a natural understanding these are going to be monomicrobial. In one case, there were 6 organisms in the blood. Now that would naturally lead us to think it is a contamination at collection or processing. What we saw was E. coli, Pseudomonas, Enterococcus, and one anaerobe and 2 other skin flora. Right. So immediately we requested for a repeat sample, though the clinician was very confident that the sample collection was absolutely aseptic. This lady had organomegaly, that is hepatosplenomegaly. There was no diagnosis. They worked it up extensively for tuberculosis and malignancies. The only presenting feature was fever, and she was an inpatient in the ICU. We repeated the sample. The next day it was this same cross-section of organisms with the same distribution. I went back to my professor in bacteriology, Dr. Pallab Ray, to understand, because in my 18 years I had never seen such a case of 6 infections, 6 organisms in blood. This was a polymicrobial. We tailored the therapy because it was conclusively proven. So we started on the coverage for this entire group, and the patient recovered. So what I saw is, in blood, we do often see those which are the traditional skin commensals, the gut commensals, and the oropharyngeal commensals. There are cases, ma'am, where they are truly polymicrobial because the clinical adjudication could be done. Gut leakage, gut translocation will invariably be a polymicrobial, because most likely it should be a polymicrobial, which we routinely miss because we don't process for anaerobes. Absolutely, absolutely.
It can be a double-edged sword also.
So what I have seen in literature as well, that while people in their statistical analysis have compared it with the standard of care methods, they have finally relied on the clinical adjudication, because culture will fail to show you what is truly there.
I just wanted to highlight that point,
Yes,
because
absolutely.
whatever case scenarios you gave were 1 + 1 = 2, you know, so it doesn't happen always like that.
It may not. In respiratory, like the polymicrobial, if you see a lot of anaerobes along with your Klebsiella, what happens is 2 cases. Suppose it's a bowel fluid.
We've had situations where we are actually, you know, then into discussions of narrowing down from the list that comes to us.
So the basic intent is, one, we have to know what is there in the sample. Next comes correlating it with the bedside, and then coming to a conclusive diagnosis, definitely. So 1 picogram of DNA. And the advantage of our technology is we do not pick up the DNA, which is called the cell-free DNA, which comes from a dead bacteria. Those are fragmented. We use nanopore sequencing, which is long-read sequencing. So we need intactness of the DNA, and an intact DNA always comes from a live organism. So that is also to answer your query, ma'am.
So you have to know what is being used by the lab, basically.
Yes, so this is long-read sequencing, uses intact genomic DNA. Cell-free will not be picked up. Cell-free are those cases where the sensitivity may be high, but it has this risk of dead
Past
DNA.
infections also will be picked up.
So here this test has proven to be very good prognostically. Just as sir mentioned, we have had other examples. Yes. It's not cartridge based, so no specific cartridges for each sample. All you need to say is infection NGS, and it will be sorted for inter-sample processing. No, sir. No, sir. So this is not PCR, sir. So the first thing is, this is not PCR. The second thing is, it's very rightly pointed out that the good laboratory practices, wherever this sample is being processed, has to be with the utmost care and quality, which we understand very well. So I can vouch for that.
Technically, it may not be PCR, but however, ultimately you look at the DNA sequence.
Yes, sir.
And if you do it in an open system, the risk
So
of
the
contamination
kit is,
is
we
it's
are
a
the,
double-edged,
sir,
extremely sensitive, right?
it is sensitive, but the points of cross-contamination, the DNA from this sample going to, during the user performing the test, shifting the DNA from this well to the other, because we were aware of this, we take the utmost, and I would request all of you, whoever can make it to our central sequencing lab, which is in Turpe, Navi Mumbai, please visit us. My teammates are here, and you can have a look for further belief on the system.
I mean, that's the concern that we have.
We have controls in every kit. We are the manufacturers of our own kit, sir, which is used for the library, which in sequencing, there is something called a library preparation for the DNA processing before putting on a sequencer. So there are small DNA segments attached to each sample DNA, which are called barcodes. Using those barcodes, any cross-contamination is very evident if it ever happens.
And are there transient colonizers, like say for example when Introviral PCR came for CSF. There was, meningitis. They found that sometimes transiently there can be some PCRs in CSF can turn positive. How does the human system works? Like this was polymicrobial blood sepsis is a kind of new thing for us. Six
Yes.
organisms. So are there transient bacteremias? Can this be picked up?
So transient bacteremias are very much there, but human system is very pro at removing those. So our phagocytes are very active. The moment they have this bacteria circulating, they would engulf phagocytose, and that is the cell-free DNA which will be there. So it is immediately cleared from the system. So we do not want diagnostic tests to be picking that up. Right.
So how would you kind of...
We don't, that fragmented DNA will never be picked up by us, sir. To answer the other point that you said, sir, I think you mentioned a point before the transient bacteremia. There was another concern you mentioned. I was thinking of answering it. The molecular biology part. Why PCRs pick up? It's an extensive discussion which I also learned from the IIT scientist who is the head of my R&D. Why do PCRs tend to have a very high false sensitivity? The primer size they use, it's too small. It's like looking at somebody's eye and trying to identify the whole face. Sequencing, on the other hand, is the photograph of the face, a longer part of the DNA being seen.
Thank you very much for solving
A
our
small
question.
query. Are there any false negatives? So like if you have a neonate with fever, if this test is negative, can we rule out bacteremia for sure?
Sir, the volume, as I mentioned, the volume of the sample, if I say my detection limit is 1 picogram of DNA, and suppose the volume that needs to be
That is
sent,
how many bacteria roughly?
so in gram negatives, it is 10 CFU per ml. In gram positives, roughly 100 CFU per ml. These are spiked experiments. Thank you so much. Thank you. Thank you, Chairperson.
Thank you, ma'am, for the wonderful session and the insights of the tools in our pediatric practice. I request our speaker and the chairperson to please proceed to the felicitation point. For all our delegates seated here, it's a gentle reminder that you all have to be present for our last session. That is the much-awaited quiz as well, which is going to be very interesting and entertaining. So please be present for the same. For our next session, I now welcome our renowned speaker, Dr. Vijay Yevle sir, and honorable panelists, Dr. Suhas Prabhu sir and Dr. Divya Prabhat sir on the dais. They would be enlightening us about the latest recommendation for childhood acute otitis media management, a Delphi study.
About his work at Wadia Children's Hospital, one of the premier institute which deals with children. So today we are going to look at what is the new recommendation. I would not say new, what is the latest in the management of otitis media, and with these experts we will answer some questions. Before I start asking them questions, I'll just quickly take you through what we did was a Delphi study consensus where we devised some questions, and 12 members across the country, including 2 microbiologists, we tried to look at the evidence for best evidence-based management of otitis media in India. And the objective of this study was to develop statement guiding evidence-based management of otitis media and middle ear effusion. And we aimed at achieving a consensus based on literature evidence and expert opinion based on real world clinical experience from participant expert, because we understand that to have very robust microbiological data from a child with middle ear infection is an uphill task, almost impossible to reach. So it is essentially evidence-based plus clinical practice-based consensus that we arrived at. As I said, there were 12 groups of experts. We initially developed 101 statements, and they were circulated to all the experts. There was agreement by more than 80% on 83 statements in the first round. So those 18 statements where there was no consensus, they were revised, and then out of those 18, there was more than 80% agreement on 15 statements. And 3 statements were again further revised, and ultimately, the 23 important statements were discussed in detail, and the out of 101, only 67 statements were approved by experts, and 34 statements were deleted to avoid redundancy or where there was lack of consensus. And this ultimately culminated into a paper publication called Expert Consensus on Management of Acute Otitis Media in India, and this has been published in the Pediatric Infectious Disease Journal. So what the study looked at, or what the group looked at, the management of acute otitis media in children. And we propose a tiered approach. From one end, you have conservative therapy to symptomatic therapy, antibiotic therapy, surgical therapy, and referral to an ENT surgeon. And what it recommends is, when it comes to treating otitis media with antibiotics, you take into consideration the laterality, whether it is unilateral disease or bilateral disease. You look at the risk factors which are associated with persistence or recurrence, age of the child, and severity. And I'm sure you must be aware that these are the factors which have been taken into account even in the guidelines which have been made available in the past as well. So a baby less than 6 months, 6 months to 2 years, above 2 years with confirmed otitis media who has severe disease, above 2 years with non-severe disease, and then one who presents with perforated TM. So these kind of segregation has been done, and then the approach or management has been proposed in this consensus statement. So the sum and substance of the management is in this algorithm. Antibiotic therapy is indicated in a child who's above the age of 6 months, who has, you try and find out if he has history of penicillin allergy. If the penicillin allergy is not there, you initiate therapy with amoxicillin. That is the drug of choice, and unlike what is mentioned in the Western book, you adhere to 40 milligram per kg per day in 2 divided doses. If there is penicillin allergy, which is mild in nature, obviously you use a 3rd generation cephalosporin, which could be either cefdinir, cefodoxime, or even a 2nd generation cephalosporin like cefodoxime is permissible. Then in case of treatment failure, which is assessed at 48 to 72 hours, you step up to high dose amoxicillin plus clavulanic acid. The purpose is to cover the probable beta-lactamase producing Haemophilus and Moraxella and the intermediate sensitive Streptococcus pneumonia, the incidence of which in India is not very high at this point in time. So you kill 2 birds in 1 stone. So you step up the dose of amoxicillin, double it to 80 to 90 mg per kg per day, and add clavulanic acid to take care of the beta-lactamase. But here, unlike your standard preparation, which has 7:1 ratio of amoxicillin to clavulanic acid, use 14:1 ratio, and lot many companies now have come up with this preparation, what they call it as ES preparation. So 80 to 90 mg per kg in 2 dividers of amoxicillin. Or the other option, in such children who fail the initial treatment with amoxicillin, failure recognized at 48 to 72 hours, you admit this child and give ceftriaxone 50 mg per kg per day for 3 days. And if the symptoms persist, then obviously you get the child admitted, work up for if there is any underlying factor, and use injectable antibiotic. There are exceptions to this recommendation. Sometimes you have children who have otitis conjunctitis syndrome, where there is a very high probability of it being caused by Haemophilus. There, instead of using amoxicillin, one could use standard dose amoxiclav to begin with. And then for severe disease, if you remember, the IAP protocol in the past recommended co-amoxiclav to begin with. Here, most of the experts agreed that it is Streptococcus pneumoniae which is responsible for almost all otitis media, and the Haemophilus piggybacks on streptococcal infection. So the group felt that one could start either with amoxicillin or maybe standard dose amoxiclav. So it is left to the individual to decide. And for severe disease, may prefer ceftriaxone for 3 days. So this is what was recommended as an algorithmic approach to otitis media in this consensus statement. And then, pardon?
Ceftriaxone of 50 mg per kg, is it an adequate dose? Because especially you are dealing with an virulent organism which is not responding to amoxicillin.
So
you are stepping up the dose of amoxi to 80 to 90.
but the levels
and
achieved,
Ceftriaxone is 50
levels
mg per
achieved,
kg.
levels achieved in the middle layer fluid at parenteral ceftriaxone of 50 mg per kg are adequate.
Dr.
Unlike
Suhas,
your meningeal. We'll discuss that when we, I'll in a couple of slides, I'll finish what we have stated in the statement. And antimicrobial therapy of recurrent otitis media, what the paper proposes is recurrent acute otitis media within 1 month of the previous episode, you switch to high dose co-amoxicillin, but because here the risk of resistance is very high, and recurrent otitis media which has occurred beyond 1 month of the previous episode, you individualize the therapy based on the response to therapy and time since the previous visit. And you must make an attempt to address the underlying risk factors. Some patients who have severe penicillin allergy, you need to use macrolide, azithromycin, clarithromycin, clindamycin, but we are pretty much well aware that though they came in the market as a respiratory antibiotic, over a period of time these pathogens have developed resistance to macrolides. So individualized based on age, severity and impact on hearing and comorbidity are the factors which are considered when dealing with otitis media with effusion. Let us not confuse the two. Otitis media with effusion is without inflammation, and one could conserve a child, keep the child under regular surveillance, or refer and to an ENT surgeon for surgical therapy. And we are going to discuss all these things in detail with the help of these experts. And this is what is proposed as conservative therapy of otitis media with middle ear effusion. And surgical therapy, you have tympanocentesis, mastoidectomy or tympanostomy tube insertion. Based on the duration of illness, the severity of illness, age of the child, functional impairment in terms of impairment of hearing. Now, having quickly gone through what is there in the consensus, it is available in the Pediatric Infectious Journal issue, the Delphi consensus statement on management of acute otitis media. Having said that, now let us let all of us understand the terminologies which are used, and let us now get into discussing why we have arrived at such a statement. So the first question, Dr. Prabhu, you may take this. What is acute otitis media? How do you define acute otitis media? Because it's something which is diagnosed very loosely.
I agree, we diagnose it very loosely because we are not in the habit of doing an otoscopy. First of all, it's really very difficult to be certain of acute otitis media without actually doing an otoscopy. So otoscopy is part of your diagnosis for an acute otitis media. So having said that, it means that you're going to look at the history and you're going to look at findings. Acute otitis media is an acute infection. That is, your patient comes to you within a few days of the infection of the middle ear cavity. So most of the time, it is bacterial. It can be viral in origin, maybe in about 25% of cases or 30% of cases. But by and large, like a lower respiratory tract infection, it is presumed to be bacterial, and therefore, if it is there, we are going to think about antibiotic treatment. So it's an infection in the middle ear cavity. So there is an inflammation there. The inflammation is reflected in congestion of the eardrum. There's a collection of fluid which turns purulent in the middle ear, which can be seen through the otoscope because you will see the eardrum turn opaque and will bulge forward once there is a significant collection of fluid. There are systemic features usually. There's usually fever, there's irritability, there's difficulty in feeding. And if the child is little older, old enough, the mother will tell you that the child keeps on tugging at his earlobe or complains. Most of the time, it is preceded by an upper respiratory tract infection. The infection actually starts from the nasal cavity and proceeds to the middle ear cavity. So many of these children start off with a running nose or a blocked nose with fever and nasal discharge. So that's, I think, very easy for us to confirm an acute otitis media, provided you've done an otoscopy. Otherwise, it's very difficult to distinguish a simple URI without a middle ear involvement from an actual otitis media.
So presence of inflammation with pain is an essential component to label it as acute otitis. Dr. Divadyan, what is OME and what is CSOM?
Yeah, as you rightly said, the respiratory tract from the nose from the sinuses to the eustachian tube to the middle ear, it's a single respiratory epithelium. So whenever there is a upper respiratory tract infection, the first stage that you see is hyperemia. There is congestion of the eardrum. So there may not be fluid. The child would complain of earache, but we label it as otitis media, but actually speaking, it's not otitis media, it's just an inflammation or hyperemia of the drum. After this, following the inflammation, the eustachian tube gets blocked, whatever oxygen is there in the middle ear gets absorbed, the nitrogen gets absorbed, and that negative pressure creates exudate inside and fluid inside, which rightly Dr. Prabhu said that that fluid inside would definitely tell us that is otitis media with some amount of fluid. So this can be either infective or it can be, absolutely a non-infective or an allergic type of fluid, what we normally call, which is otitis media with an effusion. So that is otitis media, which may be infective or non-infective. And the same stage is the first stage is hyperemia. After that, there is exudation, I said, on account of blockage of the eustachian tube. And then under the pressure, the drum bulges and there is a perforation which leads to ear discharge, which we call as a CSOM, chronic suppurative otitis media. So this discharge may be of two types, either a safe type or an unsafe type. And generally, you can say 90 or 95% of the times, roughly, we find it's a safe type. It's a central perforation. And about 5% to 10% would be an atic perforation, which would be an unsafe perforation.
But at the same time, a child who has just acute otitis media, if the drum perforates, would you still call it COSM? Or it will be acute otitis media with perforation, otorrhea?
Yeah, an acute otitis media which perforates, the moment you give your medical line of treatment, invariably all of them heal up very well. So that discharge, you would not call it a CSOM. Okay. This heals on its own because primarily you should remember that this is a self-limiting disease. It always is a self-limiting disease unless it's an unsafe ear.
Dr. Prabhu, you wanted to add something?
I wanted to add something. I think because we say chronic, it means it's going on for more than 3 weeks. So basically anything that is very short is not a CSOM. But I also want to add a point about OME. I think Dr. Divya Prabhat brought it out very rightly. OME is failure to completely resolve the inflammation that happens following an AOM. So OME is almost always preceded by AOM. When the AOM is supposed to resolve, the eardrum is supposed, the middle ear cavity is to go back to its normal state with air and ability of the ossicles to vibrate so that hearing occurs. When this fails to happen, and he rightly pointed out the reason, because there's a negative pressure, there's accumulation of fluid, and sometimes the fluid becomes very thick, and the surgeons like to call it glue ear. Do you still use that term? Glue ear. The whole thing becomes sticky and does not resolve. So that's an OME or MEE, sometimes it's referred to as ME. The important thing to remember is that OME is not necessarily an infection. It can be. I'll tell you how it can be. The situation is the same. The question is whether there are active viable bacilli inside or no. If you have a patient who starts off with an AOM and you have treated him correctly with an antibiotic, you may still end up with an OME. You may still end up in but that child is likely to have a non-infective fluid in the ear. So that patient is not obviously going to benefit from an antibiotic. Occasionally you may have a patient who had an AOM which was treated at home without possibly the correct amount or duration of antibiotics. And that patient has now come to you with an OME. There possibly can be a residual infection. So these two have to be handled slightly differently. If there's a patient that you have seen as an AOM, and you have given him the correct course of antibiotics, after that if he comes with an OME, I would safely assume that unless he has seen symptoms of fever, pain, acute inflammation, he is a non-infective OME. Because our approach is going to be different, so that's why I'm emphasizing.
And that fluid can take as much as 12 weeks to disappear.
Even
completely.
longer. Even longer
it can take.
Even longer. If you look at the data,
yeah. Quickly
50% of OMEs.
Quickly in the same breath, tell us what is persistent and what is recurrent otitis media. You can take it, doctor.
Okay. Persistent AOM is one that does not improve after 48 to 72 hours. I think you mentioned this earlier also in your talk. Because when you treat an AOM with a correct line of treatment, there has to be improvement or near resolution of this main symptom, which is fever, pain, and irritability within 48 to 72 hours, and reduction in the congestion and hyperemia of the drum. If that does not happen, that's a persistent AOM. And there are reasons for that, and that might be an indication to change the antibiotic or sometimes to call the ENT surgeon because that might need a tympanocentesis. Recurrent AOM is an AOM that you have treated, which within 1 month comes back to you with another episode in spite of having received the complete course. So that's a recurrent AOM. Now again, I'm glad you brought these questions out because your line of management in these cases are going to depend on whether it's a persistent AOM or a recurrent AOM.
So we generally say 3 episodes in 6 months or 4 episodes over a year, of which one is occurred in the previous month is that's
Yes,
the
yes.
typical textbook definition of recurrent otitis media. Okay. Dr. Divya Prabhat, how common is it in children? I mean, we have different, varying figure in the literature. Some talk about very high incidence. So what is your experience? How frequent it is?
I mean, AOM is very common, in fact, and probably as common as a respiratory tract infection. And especially in infants, we see it very often because obviously the eustachian tube is the cause. It's short, wide, and horizontal in the infants. And most of the time, they're in the lying down position, and even vomitus and milk can get into the eustachian tube and cause ear infections. So it's very common a condition.
And
I think if you look at the US data, the commonest indication for giving an antibiotic is an acute otitis media. Now we all become smart. We know that diarrhea we don't need to give antibiotic. For viral URI and coryzas we don't give antibiotics. So the commonest indication for antibiotic, at least in my practice, possibly even in most of your practices, is an acute otitis media.
And
so it's really common.
Will I be wrong if I say that each one of us has to, goes through at least one episode of otitis media in lifetime? As a child, all of us must have had at least one episode.
Right. Since Dr. Prabhu quoted the US study, American Academy of Pediatrics puts acute otitis media as the commonest cause, the number one cause for admission to of a crying child in the hospital, pediatric hospital. So it's the number one cause as far as admission is concerned.
Okay, for pediatricians, we all understand it's a disease
Some
which
more
occurs.
points about the age group?
Yeah, so
Yeah.
that is I'm coming to that. As pediatricians, we understand it is 6 months onwards, and more the disease considered in the younger age because of the anatomy of the eustachian tube. But Dr. Prabhu, what about children below the age of 6 months? Do they not get otitis media? And how does it differ, if at all they get?
They do, but the problem is it's really difficult to do an otoscopy in a very small child, below a few months of age. Also, I would say it's probably more common the younger the child is because, as he rightly mentioned, Dr. Divya Prabhat mentioned all the causes. The child is lying down, is breastfeeding, there's a negative pressure suctioning that is happening, there is regurgitation, there is posseting, there is milk probably entering the eustachian tube. But these children are unable to localize. When you have an older child, an older child will say, ear is paining, touch the ear. A younger child, as I said, the mother will indicate that, child seems to be touching the ear or has difficulty while swallowing, while breastfeeding. So you have some idea that swallowing is painful, possibly because of the ear. In a younger age group, it cannot be said. So localizing the infection to the ear is very difficult. So which is why, as you rightly put your next question, below 6 months, we would be very careful when a child you think has got an acute otitis media. Also, in this age group, the infection can spread very rapidly. There's a higher chance of developing septicemia, bacteremia, and even meningitis. So we need a more aggressive treatment when you treat an AOM. And therefore, I think when you mentioned earlier, you spoke about what to do in a child above 6 months. Below 6 months, we require entirely different criteria.
Most of the guidelines you look at, they talk about treatment of otitis media above the age of 6 months. 6 months to 2 years, at 2 years and above. I came across a few papers where they have talked about otitis media in younger infants below 6 months, but say between 2 and 6 months. And surprisingly, the microbiology is same as that of a child above the age of 6 months. But as Dr. Prabhu said, younger the child, more is the risk of dissemination and it going unrecognized, and it is treated as a part of sepsis in very young neonates. Okay, Dr. Divya, what are the common pathogens associated, and is there any Indian data, or we just borrow from the Western literature that strep pneumonia, Haemophilus moraxella, blah, 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 blah?
We can ask him how many tympanocentesis is done for acute otitis media. I think the world record in that is from Ron Dagan in Israel.
Yeah.
And even in Finland, they do tympanocentesis for almost every AOM to find out what's the organism. We don't do it in our country, which is why, as Vijay said, we have to rely on the Western data. So the Western data probably is applicable to us is strep pneumonia, possibly at least 50% of the cases. Moraxella and non-typable H. influenza. These are, I think, the main organisms that you will see in an acute otitis media. In a CSOM, you see sometimes little different organisms. You can see, for example, Staphylococcus visi. I'm sure you've seen Staphylococcus, which can, then have mastoiditis and other things. You do see CSOM, for example, in cystic fibrosis with Pseudomonas and other gram-negative organisms. But in your acute run, in your general run-of-the-mill AOM, it's strep, H-flu, Moraxella. Now, why is this important to know? Because our antibiotic choices are going to be empirical. They're going to be based on what we think is the organism, because we cannot look at this organism. I mean, you cannot identify the organism unless Dr. Divya says, I'll do a tympanocentesis and send it to the lab.
Yeah, I think we do quite a less number of tympanocentesis, because our pediatricians treat it very well,
Either pediatrician treat or there is spontaneous tympanocentesis. But a word of caution.
A word of caution, yeah. You spoke about spontaneous tympanocentesis. That's a big problem. If you see a discharging ear, you see otorrhea, you say, oh, now my problem is solved. I don't have to call Divya. I'll just take a swab from there and send. You will be mistaken. You're going to get polymicrobial because the flora from the ear canal and everywhere is going to get mixed up. So that's not reliable. If you really want to find the organism, you need a tympanocentesis.
And I'm not exaggerating. We have had referrals for this cause, that the ear discharge was Pseudomonas. For injectable antibiotic, please admit the child. Anyway, so and Dr. Prabhu, you mentioned that, common passage. So how well does nasopharyngeal pathogens correlate with otitis media?
It doesn't correlate very well. Because we know that nasopharyngeal organisms can be simple commensals. We know that 30 to 40% of preschool age group children will have strep pneumonia in their throat. That's not necessarily the organism that is in the middle ear fluid. Yeah. So we don't really have a source to identify the organism.
But if you look at the evidence, there is a paper from Chandigarh systematic review, and they have also said same thing, strep pneumonia, Haemophilus moraxella. And Dr. Balaji conducted of course, on patients with otitis media, he has tried to look at the nasopharyngeal pathogens. And in such patients, there is a reasonable correlation. Dr. Divya, you want to say?
Yeah, I had a paper on this where, we did tonsillectomy, and before the surgery, we took a swab, and after the surgery, when the same child, we removed the tonsils, from the crypts we sent the swabs. So both of them were different. So taking a swab from the surface and something within is totally different. So I don't think that makes a...
Okay, let's now come to the crux. Dr. Prabhu, strep pneumonia, Haemophilus moraxella, all of us agree are the pathogens, and of course viruses. What is the antimicrobial susceptibility as on today? How well is the drug concentrated in the middle ear fluid?
I think you already mentioned that the drug of choice should be amoxicillin, because we have strep pneumonia as the commonest organism, but we don't really have drug-resistant strep pneumonia as a major problem. We also know that acute otitis media is in an older child at least not such a dangerous condition that I would, be afraid to give him the wrong antibiotic, because as the patient comes back after 48 hours, you have an opportunity to change. So I think amoxicillin, as you rightly showed earlier, 40 milligram per kg is my drug of choice. It will cover all the strep pneumonia, at least most of the strep pneumonia, and possibly some of the Moraxella and the H. influenza. More of the H. influenza, Moraxella is generally resistant, but that's not the commonest organism.
So strep pneumonia in our country is still susceptible. I must talk about the resistance among strep pneumonia. It occurs by alteration of penicillin binding protein. The intermediate resistance in the strep pneumonia to penicillin can be overcome by doubling the dose, and that population is very small. That percentage is very small in our country. And so far there is no data to say that there is increase in the intermediate resistant streptococcus pneumonia. And that's the reason we have deviation from the Western guideline of 80 mg per kg amoxicillin. As against that, we recommend, and we continue to recommend 40 mg per kg per day of amoxicillin. And the amoxicillin is reasonably well concentrated. Though there is a debate, there are some microbiologists who believe that the PKPD is such that the middle ear fluid should be treated like meninges, and what is applicable to meningitic dose should be applied to otitis media. Dr. Prabhu, your comment on this?
No, I think I would say the proof of the pudding is in the eating. While somebody else earlier mentioned that is ceftriaxone 50 milligram per kg enough, or should you use 100 milligram per kg, which is your meningitic dose or septicemic dose? We find in practice that when you use lower doses, you still get a response. So whilst there is some doubt of what is the constant in the middle ear fluid, I think overall when you use 40 milligram per kg, you will get adequate levels in the middle ear fluid above the MICs for a reasonable length of time to achieve a cure.
Okay.
So I would still say 40 milligram per kg is fine.
40 is working. So Dr. Divya Prabha, which patients do you follow, allow them to wait or manage conservatively without starting antibiotic? Ante nakat them, kanat them, all just
Yeah.
please elaborate.
Yeah. So basically, rather than concentrating on the ear, I think it is important that we also concentrate on the nose. And invariably, the cause of otitis media somewhere lies in the nose. You know, whether the child has allergic rhinitis, there is sinusitis, there's a postnasal drip, whether there is adenoids, there is mouth breathing itself. So importance would be even to, actually examine the nose more, see with the tongue depressor, whether a misting is not there or, air blast is there, a simple test. And secondly, I would like to not wait for those children who repeatedly, even after our antibiotic courses or medicines, we just do an impedance audiometry. It takes 2 minutes and we exactly know the condition of the middle ear. So if it still shows a flat graph, the problem is that if fluid remains in the middle ear over a longer period, it develops certain toxins, and these toxins percolate to the inner ear, to the cochlea, and leads to a sensory loss also. So it becomes a mixed loss, and that sensory component does not improve later. So I would not wait if there is a fluid which is persisting on an impedance audiometry. And another common thing which we see quite often is children who come for LD or they're coming, with these learning disabilities. You find, we check them up, you drain the fluid and automatically you find them, improving after that. So these are the things where we would not like to wait.
And Dr. Prabhu, all of us have agreed in that statement also that a child above the age of 2 years, mild disease, unilateral disease, one would not immediately jump to prescribe an antibiotic, but watchful waiting with some nasal decongestant. And know what are your views on eardrops? Otic, AC, and yeah.
So basically, as far as otitis media is concerned, one is that they should not use masala eardrops because of the combinations that, that would lead to secondary issues which are all aware. But many a times when we have these children with earache, it may not be otitis media. It may be just a myringitis. When we see them under the microscope, it's only an inflammation which is like a viral. So there a eardrops does help them to relieve the pain. It may be only a myringitis. There may be just little granulation over there, which they get relieved. But otherwise, the role of eardrops is not there as far as otitis media is concerned.
And we talked about 40 mg per kg, and Dr. Prabhu, we agreed that there is a change in the recommendation in the Delphi consensus that we say regardless of severity, your starting antibiotic should be amoxicillin unless you have otitis conjunctivitis syndrome. So and in the past, the IAP guidelines and most of the Western guidelines also talk about co-amoxiclav.
Yes.
If the disease is severe, and especially in a child who is below the age of 2 years, because of the high risk of developing complication, the old guidelines mention to start with co-amoxiclav. We have changed to standard dose amoxicillin.
You said that earlier.
Having said that, what is the duration that you prescribe it for?
That's the other problem, that most people who unwittingly, most pediatricians or family physicians who give an antibiotic for an unrecognized otitis media will recommend it like for a URI for 5 to 7 days. And that's not adequate. You need to give at least 10 days, possibly 14 days. My practice is to call the patient back, examine the eardrum and make sure everything is fine before I tell him to stop the antibiotic. So I would say minimum 10 days, possibly 2 weeks.
Now last 2-3 important questions. You have started amoxicillin, you have called the child again at 48 to 72 hours. The pain persists, hyperemia is still there, and child is not improved. What is the next step? And to be precise, why have you recommended high dose amoxiclav and not high dose amoxicillin? And what are the specific indication to use this high dose co-amoxiclav?
Okay, so once the patient has not responded in 48 hours, let's look at the bacteriology. Either he's got a DRSP, in which case he's not going to respond to your 40 milligram per kg of amoxicillin, so he needs 80 milligram or 90 milligram per kg of amoxicillin, Or else it is H. influenza moraxella, which is a beta-lactamase producer, so you need to add the clavulinate. So adding these two together, you're going to need 80 to 90 milligram per kg of amoxicillin, plus you're going to need the clavulinate, which calls for this combination that you just mentioned. Now this combination, as you rightly said, is now being marketed by many companies, but before it was marketing, my practice was if the patient didn't respond to 40 milligram per kg of amoxicillin, I would simply ask him to continue and add to that 40 milligram per kg of amoxiclav, or the standard dose, that is 7:1. So that gives exactly the same thing.
Correct.
So that's what I would do, but now you have a ready-made preparation which you can just switch.
Now, one question which is very often asked by many members is that on one hand we said that you did not use co-amoxiclav, begin with amoxicillin even if it is a severe otitis media, because almost all otitis media is caused by strep pneumonia. Now, having said that, when the 40 mg per kg fails, why not just double the dose? Why add clavulanic acid?
No, because already 48 to 72 hours have gone. If the
Yes, it could be, on one hand we said that it is strep pneumonia. So the fact that the child has not responded, that means probably is harboring intermediate resistant strep pneumonia.
But it
so
could
why
also
not
be
use
H. influenza, how do you know?
Yeah, so 100%
in order
ruling
to
out is
cover
not
both,
possible.
otherwise you will have to do it three-step process.
Three-step, yeah.
So rather than that, at 48 to 72 hours, I would give this combination that you mentioned.
So please try and understand the philosophy behind that 40 mg per kg is the starting dose. If it fails, not only do you double the dose of amoxicillin, but also add clavulanic acid, and to avoid the adverse effect or intolerance of clavulanic acid, where 14:1 suffices, that's the place where you use this new combination of 14:1. So you cover intermediate resistant strep pneumonia as well as moraxella and Haemophilus, which produce beta-lactamase. So this is the logic behind recommending high-dose co-amoxiclav. Where else would you recommend high-dose co-amoxiclav? Would you recommend it to a child who has recurrent otitis media or persistent otitis media?
In a very sick child, in a very young child, in a child who's recently received a full course of amoxicillin in whatever your standard dose, and within a month he's come back, I would strongly suspect whether we have missed completely eradicating the previous organism, he's likely to be drug resistant. So this is the kind of patient I would directly start with this combination, 14:1 amoxiclav.
So should we take home the clear message that high-dose co-amoxiclav only in child who has failed treatment with 40 mg per kg or who has had recurrence, especially if it has occurred within the month?
Within a month. If it's after 3-4 months, I would still start with 40 mg.
And persistent otitis media, not only do you use this antibiotic, but also address the underlying risk factor, both in persistent and recurrent. Okay, that's very clear.
And also very sick and very young children.
Very sick and very young children. Dr. Divya, what are the complications of otitis media and how commonly do you see them, and how do you counsel the parents about them?
The commonest thing that we see will be mastoiditis. They come with mastoiditis, it becomes a mastoid abscess later on. The second thing which we see is facial paralysis. They come with facial weakness, where we immediately do a tympanocentesis, or would be meningitis. I mean, these would be the commonest ones in that order.
And perforation, of course.
Perforation, in fact, it'll be good. If it perforates, it'll discharge so that it won't cause any complication.
And
naturally.
Yeah, that's a natural healing. It's a combo, yeah.
So, more important than that, these are of course dangerous complications that you mentioned. The more dangerous complication, I mean, in my point of view, is an OME that you are missed. Because unless you have examined the eardrum, the child will end up with some amount of hearing loss, unrecognized, which will cause a lot of problems later.
Absolutely. So now, Dr. Divya, I have had a child who has a otitis media. I have given antibiotic. I have called him at the end of antibiotic therapy. I still find there is fluid behind the eardrum, but there is no inflammation. So I label it as OME. Now, here onwards, how do I follow him up? How often do I call him? Do I need to do tympanometry or pneumatic, I get nominal aphasia.
Impedance audiometry.
And, impedance audiometry. Yeah. And how do you manage such a child?
Yeah, basically, I mean, if it's not responding, it is very important that you treat the nose. And once you treat the nose, most of them clear up. You require to do an impedance audiometry, which is a very objective test, and it can be done in newborns also. So impedance audiometry, if it still does not improve after your nasal treatment also, maybe for 3 weeks or so, then you should consider a tympanocentesis. Otherwise, the future, the child can get hearing issues, can get a cholecystoma, can get other complications later on. So important is treat the nose, repeat an audiometry at least twice at an interval of 3 weeks.
Okay.
And only then one would consider a tympanocentesis. And at the same time, maybe, you know, the child may have adenoids or, in fact, the last patient I was keeping for a tympanocentesis, Dr. Prabhu said, no, you have to do an adenoidectomy. So I did the adenoidectomy along with the tympanocentesis.
I have a
I think we need to remember that OME sometimes resolves on its own. If you look at the data, 50% of the patient will resolve at 1 month. So what he said, wait for 3-4 weeks before you jump to do anything is very valid. Another 30% will resolve in the next second month. But after that, the rate drops very rapidly. After 3 months of age, 3 months after it started, the OME, the chance of resolution after that are very low. So 3 months is definitely my indication to send to Divya or whatever for some kind of treatment or the other. And as he rightly mentioned, one can be a tympanocentesis to try and drain the ear. The second option can be to put a grome. After that, doing a tympanocentesis. And the third, of course, is to remove any kind of obstruction in the nasopharynx like adenoids. All three or in turns or one or the other might be required for every patient. But I would wait a couple of 2-3 months, follow up carefully for the impedance audiometry to see whether the patient is getting better or not.
So
Can I ask you one or two questions? Sorry. One thing is that what is the difference between OME and MEE, middle ear effusion only,
Nothing
and
really.
OME? Are they same?
Same.
They are
Or
the same.
OME means evidence of inflammation on the tympanic membrane, and then as Suhas said that it can last for 3 months. The other thing is that we are insisting on impedance audiometry. Can we substitute that in a verbal child with Weber's or Raynaud's test? Can it be kind of equivalent? Because ultimately we want to detect conduction loss, and if the Weber's test is localizing, then I think we do that in our practice usually. What's your opinion about that?
Basically, effusion most of the time has an allergic background or may have an adenoids. And with this condition, both the ears will be involved and practically equally. So if you do a Weber's, it would not lateralize. So definitely you require to do an impedance audiometry.
Raynaud's will show because air conduction, bone conduction better than air conduction. I have fluid in the middle ear. That because see what I'm saying is that
I'll answer.
in institute, say for example in Jupiter, I can easily do impedance audiometry. But in my clinic, to send each and every patient with OME, and as Suhas said that we have commonly seen that OME lasts for 3 months or so. So to send them every monthly for impedance is little too much of a recommendation. That's what my thinking.
I'd like to answer your first question also. Is OME the same as MEE? OME talks about what follows an acute otitis media. AOM is followed by OME in many cases. MEE, as he rightly said, can have no infection at all to start with entirely. But the physiology is the same. So I would look at treating them in the same manner, except that the OME has been preceded by an acute infection. So the only additional point I would think of is there some infection left untreated? So that's the only additional thing between OME and MEE. Coming to their question about Raynaud's and Weber's, whether you can use that instead of an impedance audiometry, there are problems. One is the fact that you can have bilateral otitis media and then you will not know, your Raynaud's is not going to. And secondly, I think you need to quantitatively look at whether the impedance audiometry is improving or not, because you can see the waveform keep changing. Will a child reliably tell you in a Raynaud's that it is better or worse than earlier? How do you quantify it? Because you're looking for, you see, we have to look at how the improvement is happening. So the only way of quantitating is to do an impedance.
So, how important or significant is that quantification required? Because, say, mother says this child has had otitis media, आणि हल्ली त्याला ऐकायला येत नाही नीट. So, impedance audiometry is the way to go. But as Sudhir says, many of us do not have access or it is not practically possible. So, is there any, say, substitute for a general pediatrician?
First, I'll answer Sudhir's question. As you said, you'll do a Weber's. Firstly, if both ears are involved, Weber's won't lateralize. Secondly, you are doing a Raynaud's. Now, when you do a Raynaud's and there is a sensorineural involvement over there, Raynaud's will still be positive. So, where will you detect? And having sensorineural loss with an otitis media is criminal actually, because it's an irreversible thing. So,
the younger child, I understand. No, but what I'm saying is that, because the discussion evolves, they say that till OME evolves. That means what would that mean? Every monthly I do impedance, and otitis media is not uncommon. So in a normal OPD, we might say 4 or 5 otitis media patients in our pediatric OPD. So to send all of them for impedance so frequently, is it rational? Is it recommended? I mean, that's the question.
Now the second commonest operation done in the world is myringotomy and grommet insertion, and which is after just circumcision. So if you remember that, like even if you take data from UK or US, it is so high, but in our country we don't see it so much. People don't do so much of grommet or myringotomy. The reason is we are missing it. We do more of cholecytoma, we do more of tympanoplasty. So probably if you had done more of myringotomies and a grommet, we would not have damaged the ear to that extent.
Okay, Dr. Divya, when do you
I want to add one thing. See, there was a time when we said, I'm talking about 15 years back, blood culture is not available everywhere. Is it really required to do that? Can we not do a Vidal? So I think the same thing we can say for this. Why not do more audiometries, impedance audiometry? As he said, it's a 30-second job, 2-minute job. It's non-invasive. It's not that expensive. So why don't we do more of it? ENT people are there everywhere.
Or another thing you can do is now otoscopes are available. You just put in the otoscope and you get the graph in the otoscope itself.
Achha, that you mean to say that pneumatic
So, I mean,
otoscope.
you have heavy practice, you can do it. I'm using so many patients.
Pneumatic otoscope we don't use. We use
I'm
usual.
saying if you're seeing so many patients
Pneumatic
and you
otoscope
feel that
is
you
something
require it, you do it yourself. Don't send it anywhere actually.
Okay, Dr. Divya, you said myringotomy and tympanostomy too. And or. When do you do myringotomy? When do you do
Now,
both?
If it is otitis media effusion, that is without any inflammation, without infection, the thing, as Dr. Prabhu said, it lasts more than a month. It's a residual thing. So by doing a tympanocentesis, it will bound to recur. So therefore, I would always put a tympanostomy tube at the first sitting. It is not a drainage tube. It's a ventilation tube. It requires to oxygenate the ear, and as it oxygenates, it reduces the inflammation in the middle ear and it opens up the eustachian tube. So tympanostomy tube has to be put, and myringocentesis is not the answer for this.
Okay. So I think we have made it very clear the indication to use high-dose coamoxiclav and the recommendations on using standard dose amoxicillin. And we had very interesting discussion and questions also. Is there any, he wants to ask something, Dr. Dingan.
Does the management of OME depend upon how severe is the hearing loss? Like, would you still wait long enough for a month if there is severe hearing loss?
In severe,
especially in a younger child, who is
in a younger child, first of all, it will cause delayed speech. Secondly, academically also they get affected, like typically what we see with an adenoid. And thirdly, if it leads to a sensory loss, I mean, we cannot recover it. So obviously, I would go in for it.
You'll be more aggressive in a
Depend
younger
on 3 things.
Yeah.
One is the age of the child. If you have an older child who's already acquired most of his speech, I'm not so worried. Secondly, the duration. As I said, if it's very early after the AOM, it possibly will resolve, so you can wait. And thirdly, what effect it is having on his schooling or on his interaction with his peers.
So one very, very pertinent question, because you said less than 6 months, otitis media, different approach. We see babies less than 3 months also coming with ear infection.
Yes.
Do you think we should admit them and give them IV antibiotics because they are less than 3 months?
Especially less than 3 months, yes. But I
Definitely,
told you, I
yes.
came across a few papers.
What about
where
less than 6 months then?
3 to 6 months, more or less the microbiology is same. And I mean, it will have to be individualized. I mean, we'll be able to make a generalized recommendation.
Admit patients for less
than oral antibiotics. Sudhir, you have a...
Less than 3 months febrile patient, we should admit. Yeah. But less than 3 months without fever, only OME, there is no indication to admit. I mean, the indication to admit if there is fever associated. Yeah.
I agree. Yeah. Sudhir, sometimes you got a young child who's come with a draining ear. By this time, the fever and all is gone. I would not admit that child.
Absolutely, that's what it is.
But 3 months to 6 months, I think, if there is a definitive diagnosis, one could use antibiotic like in an older child.
I could put him on an older oral antibiotic.
Oral antibiotic. Yeah, the organs are pushing me out. Thank you so much. And they are available. We can still discuss over. Thank you.